The clinical scenarios for perforation, mainly we're looking at pulmonary atresia with intact ventricular septum, although obviously not all are suitable. We can also apply it to patients with membranous pulmonary atresia with other problems, including ventricular septal defects or more complex congenital heart disease, in other words, single ventricles. And in a separate group, there are the patients with pulmonary atresia intact septum, but with a very, very severe tricuspid regurgitation, most of which would have Epstein's anomaly. And these are a slightly different group, both in terms of the technique, but also in terms of the outlook. And I think it's important when the pulmonary valve is not opening to exclude functional pulmonary atresia. In other words, if you have a widely open duct, the pulmonary valve may be closed in a functional sense. As was mentioned, you have to be selective, and we're looking largely on echo initially to see the morphology of the right ventricle, whether it's unipartite, bipartite, or tripartite, but also to measure the tricuspid valve annulus and to look at the Z-score, because if it's less than -2, then it's likely to be a septatable heart. If it's between -2 and -4, it's a borderline situation, and -4 upwards, it's likely to be a single ventricle outcome. And also it's important that during angiography to look for coronary arteries, because sometimes some of the coronary arteries are connected to the right ventricle and they're dependent on the right ventricle. So if you deflate the right ventricle, then you can finish up with serious problems. In terms of the technical details, very similar to what Tefik described, we generally try to go with a Judkins right catheter, usually a 2.5 curve. I usually prefer to use a guide catheter, and the one I prefer, though it's not the only one, is the Cordis bright tip, but there are others. It's important, as again mentioned by Tefik, that you do a subpulmonary angio. This is highlighted by Kevin Walsh, because many of these patients do have a way through. Biplane, I think, is very important, particularly for perforation, because when you're perforating, you need to make sure that you're in a coaxial position in both planes. Otherwise, you may perforate outside, and that's fraught with danger. Once you're actually in the subpulmonary position, a very slight anti-clockwise rotation is what you need to try and get it aligned for coaxial presentation. And this is a very subtle tip which Lee Benson recommended in the past. I usually don't enter into the arterial side, but for those who do, you can place a gooseneck snare in the pulmonary artery to help you orientate your perforating device, which could be some kind of wire. Once we cross, then we start with a coronary balloon followed by a valvuloplasty balloon. In terms of the perforating methods, you can either use the stiff end of a coronary wire, but this is not really, from a direction point of view, it's not very helpful. Most of the coronary balloons are monorail, and it's very difficult to actually use that kind of wire to go over the stiff end. So the commonest approach is to use a radiofrequency wire, either using the Baylis system. This has a high voltage system, and it actually creates a spark, and therefore it tends to destroy cells. So it literally creates a hole. The Osipka system is a slightly different system. It's a low voltage system, so this desiccates the tissues, and then it actually perforates its way through. So they have slightly different characteristics. But the commoner one that is used, because it's more specific, is the Baylis system. Laser is an option, but for technical reasons, this has not cottoned on. You need the equipment, you need the protection of staff, and so on. But more recently, the use of chronic total occlusion wires has become very useful for this procedure. Most catheters laboratories do have these wires because the coronary people use them a lot. They're relatively cheap compared to the system that you have to use for radiofrequency and so on. In terms of the technique, therefore, an RV angiogram gives you the anatomy of the right ventricle, but also the pulmonary valve. You need to see it in two planes. And when you do a little angio under the pulmonary valve, sometimes you see no flow. So you may need to do a little bit of a more generous angiogram to actually see the way through. And if you see a way through, then using a standard wire, usually a super floppy whisper or something like that would be sufficient. But you can also use a fielder, which is a CTO wire, but on the gentle side. In terms of the kit, apart from the generator, which is shown at the bottom there, which gives you the output and as well as the time. So we generally go for between 3 to 5 watts for 1 to 2 seconds at the most. You have the wire, which is the perforating wire, and on top of that you can use a braided microcatheter so that you have more stability and you can put a much stronger balloon. The CTO wires, several companies do them, but the largest selection, as I mentioned earlier, are made by the Japanese company Asahi. And there are the properties of these wires varies. It's very different. And you try to go for the lowest tip load to start with because they're the safer ones. So the feeder is one of the more gentle ones. You can then go up to the ultimate. We don't use the Astato for this. These are very, very, very, very stiff wires, and they're largely used for very severely chronic total occluded vessels like veins or arteries in the periphery. They have a very, very high perforation rate if you use them for the heart. And there are different types of chronic total occlusion wires, including the covering, which is usually a polymer, and the stiffness of the wire, which gives you the different tip loads. In addition to the wire, you can, if necessary, use microcatheters that go along with these wires just to stiffen them up, similar to the braided catheters that you get with the PA-İVS wire. And again, there are different companies that make these. The ones that we tend to use most are the Fine Cross and the Prograde. In terms of the chronic total occlusion wires, it's very important to understand the properties. They don't all work the same. So some of them you have to drill, in other words, like rotate it. In other words, the stiff ones you have to actually penetrate, so you move the wire up and down, and in some others you just simply slide them through. So it's important to understand the properties of the different types of wires. Once you've got your angiogram, you can then use your wire. As you can see there, this is a PA-İVS wire, and once you've gone through that, we use a coronary balloon, then a valvuloplasty balloon, and you can see you can get quite a good result. Some of them do indeed have infundibular stenosis and may benefit from valvuloplasty, sorry, from beta blockers. I generally don't go into the artery, but I tend to do an angiogram through a PFO to have a look at the position of the pulmonary artery. This gives you the direction and the lateral projection of where the pulmonary artery is, and that I think is important. Once you've started the generator, you can move the wire. Once you see it moving like that as it did, you need to make sure that you don't give any more energy because you can easily perforate the front wall of the pulmonary artery. I was actually assisting with this case, and the operator was very happy with this position because it was considered that the wire was in the right pulmonary artery and therefore very stable. And I raised the question because it's taking the shape of the heart, whether this was in the pericardium, and in fact it was in the pericardium. So I think it is very important to appreciate that the pericardium overlaps over the main pulmonary artery, and you can easily go into the pericardium from the main pulmonary artery. And once you've done that, gone back into the main pulmonary artery, you can use the braided catheter to have a much better track for your balloon. And once you're there, then it's very similar to what Tevfik described, using a balloon. Obviously, this was one that burst. I'm not going to mention the name of it. But the waste at least went by that time, and then you can see the result at the end of that. Having the wire in the descending aorta usually gives you more stability, and if you're having problems crossing, you can push the wire right down to the femoral. You can hold it down with your fingers over the femoral artery, and that gives you a little bit of countertraction. These groups of patients with either severe tricuspid regurgitation or Epstein's anomaly can be a little bit more difficult because the right ventricle is not particularly large and you have a lot of tricuspid regurgitation. So stability is a big, big issue here. But once you've actually perforated, and this has actually gone through the pulmonary valve, main pulmonary artery, ductus arteriosus, and up into the ascending or retrogradely into the aorta, but that gave us enough stability, and obviously you can then do the same things as for critical pulmonary stenosis using a small coronary balloon followed by a valvuloplasty balloon, and with quite a good result at the end of it. But initially, to actually have a stable position with these group, they can be quite a challenging case. Now, sometimes, obviously, these things don't necessarily work largely because of the size of the right ventricle, in which case we do have to consider other options, whether that's pharmacological or stenting is a different, it's up for discussion, and this was one particular case where the right ventricle was small, and we elected to stent the deduct. You can see that the valve was in fact very, very, very dysplastic, so you can see that you're going to get a very unreliable result. In terms of care, again, Tevfik described this as well as Omar did, and I think the algorithm is pretty much the same. Prostin, beta blockers, maybe captopril, and then consider atrial septostomy for some of the other cases. So in conclusion, pulmonary arteries and intact ventricular septum is very often amenable to valve perforation, whether you use radiofrequency or CTO wire. I think CTO wires are getting on the increase, and Masni Alwi and a group from New Delhi have described these in a small series with very, very, very good results. Remember also that although these are very good results, with CTO wires, there is always the possibility of perforation. So it doesn't mean that you only get perforation with the radiofrequency wire, you can get perforation with these as well. So aim for getting for using the CTO wires with the lowest tip load to start with because they're safer. The aim is to achieve a biventricular circulation, and the main complication is tamponade, although others are present, and Tevfik described these very well. So remember, if the wire is taking the shape of the heart, it doesn't necessarily mean that it's in the pulmonary artery. It could well have gone into the pericardium, in which case you don't proceed. You just take appropriate action to confirm that and to stop any bleeding. In other words, reverse the heparin and so on and so forth. And radiofrequency is still the commonest method, and probably the Baylis is the commonest system used, although OSIPCA have a system that is also compatible with perforation. But I think CTO wires are much more likely to take over in the future because of availability. You don't need special equipment, and they do the job very nicely. Thank you.